Yes, sir.
Good evening, everybody. Welcome to this ward rounds. Ward rounds is a essential part of the examination armamentarium, where the examiners take you through live patients who are either pre-op or post-op to assess your ability to think on your feet and use your 3 years of experience, um, hopefully that you have gained by managing patients on the ward. I think that is essentially what the ward rounds, plan, is supposed to assess. So it is not an in-depth, inquiry into something, which sometimes can be if the student is doing well, but generally it is to see how, the particular student will look at either a preoperative problem where the patient is coming to the ward and he needs to be maybe worked up before he's taken to the theater, or post-operatively situations where patients who have had surgery and suddenly you are called to see the patient. So that is generally the template for a ward round. So we will go through whatever patients we have at the moment in the ward. So who is presenting? Vinod, you are
Yes, sir.
presenting?
Yes, sir.
Yeah.
20 years, 28 years old female came to the emergency with the abdominal pain, sir, which is in the upper abdomen since 2 days, which is continuous, colicky type, radiating to back, which is aggravating after taking food intake and relieving partially with medications. And there is no other symptoms like vomiting, nausea, fever, altered bowel habits, loss of weight, and appetite. And past history, there is no medical comorbidities, and she underwent two C-sections, which is in 2018 and 2022. And general examination, patient was moderately built and nourished, and there is no symptoms like signs like vela, ictra, cyanosis, clubbing, edema, and lymphadenopathy. And general examination, vitals were normal, BP 120/80, pulse rate is 64, respiratory rate 20,
Yeah,
and
we can see all that. Yeah, vital signs were normal. Okay.
yes. And systemic examination was normal, and parabdominal examination, abdomen is soft, and tenderness is seen in the present in epigastric region, and there is no guarding or rigidity, and bowel sounds are present. Investigations, routine investigations are normal except LFT, which showed deranged SGOT and SGPT, and GGT, ALP, and there is increase in pancreatic enzymes like serum amylase 624 and serum lipase 1991. And USG abdomen was done.
Okay, wait.
Yes, sir.
Now, what do you think this lady has clinically?
Sir, mainly gallstone induced pancreatitis.
How do you know it's gallstones?
Sir, GGT, LFT was deranged, showing obstruction, something like SGOT, SGPT, GGT, and ALP.
No, I think the alkaline phosphatase and GGT are not that particularly raised.
Yes,
Even
sir,
SGOT, SGPT are probably higher than that. So how can you say this is gallstone-induced pancreatitis?
so
No,
mainly
I think
pain,
you shouldn't
pain
come
is in the. Yes, sir, yes, sir.
without any proof that you have gallbladder stones.
Sir, two things are mainly in my mind, sir, when I examine the patient, because the pain is in the epigastric region, and
So
more.
epigastric pain is due to pancreatitis. How is that due to gallbladder stones? No,
Yes,
it
sir.
is one of the possibilities, but you
Yes, sir.
said very conclusively, very confidently that it is gallstones. You can't make a comment like that.
Okay, sir.
You can have a lot of other symptoms. She's a young girl. She can
Yes,
have
sir.
hypercalcemia. She can have hyperlipidemia.
Yes, sir.
It can be other congenital causes like, annular pancreas
Yes,
or
sir.
pancreas divisum. It can be idiopathic, though at the, she's probably not an alcoholic, so you can't, or she has not consumed alcohol, so it can't be alcoholic. Or it
Yes,
could be viral pancreatitis,
yes, sir.
mumps and other Coxsackie virus and all these things. So there are so many other causes for pancreatitis.
Yes, sir.
You can only say that there is. Do you think this is a mild or a moderate or severe attack of pancreatitis with
Sir,
these investigations?
Mild pancreatitis, sir.
Anybody? Hello? Hello?
We agree with, I agree with the mild pancreatitis, sir.
Who said mild? Nikita,
Sir,
nobody said mild. So if you are saying it mild, why are you saying it mild? Mild pancreatitis.
because of the enzymes level, sir.
No. I've told you so many times. Why do you talk
Sir.
like this? See, amylase and lipase levels are not prognostic. It doesn't mean if you have a amylase level of 2 or 3,000, it is more severe pancreatitis. It is more definite pancreatitis. That is all. See, amylase and lipase are not prognostic. So there is no need to repeat their values on a regular basis. When do you repeat amylase and lipase, Nikita?
Only after 8 days, sir.
Why?
Generally, they will settle by 8 days, sir. If it is a
No, but why do you want to, it has settled. So why do you want to repeat it?
in the second episode or
Praveen, why do you want to repeat amylase and lipase?
Sir, to check the chronicity, sir.
No, it's not chronicity. Abdul?
Actually, there is no role of repeating the amylase lipase.
That is the correct answer. But what is the caveat to that?
Provided the patient, the symptoms are not improving beyond a point, or you've done
Correct.
an
See,
intervention.
that is the main thing. You
Yes.
only repeat it if, for example, a patient who was getting better suddenly starts deteriorating, abdomen starts distending. So then you think there is one of complications of relating to pancreatitis. Only then you repeat it after 7 days or 8 days, because the original increase that has happened would have come down by then. And if the patient is not recovering, only then you repeat the amylase and lipase. Even then, probably it's not required, but you would have probably, if there is any other thing you want to see, but you can repeat it then. Otherwise, no role for repeating. Now, please understand, all of you, that high levels of amylase and lipase does not mean it is more severe. So, if you look at the Ranson's prognostic criteria or IMRI's or Glasgow prognostic criteria, and of course, the others are not so extensive, so you can't quote them. But Ranson and Glasgow have stood the test of time. They have been there for a long time. Their only problem is that you will have to, wait for 48 hours to prognosticate, because some of the results, some of the values are at admission and at 48 hours. So, you will have to wait to see if this patient is mild or so. The newer ones, you can make a diagnosis or prognosticate them very early with the BISAP grading, BISAP scoring system and things like that. You can actually, PANC 3 is another one. So you can make a decision very early so that you can manage the patient more efficiently. But amylase and lipase, for example, if it is marginally raised, then it can be raised in so many other conditions. Nikita, can you list out what are the conditions where you can get hyperamylasemia? Praveen? What is this silence? Vinod?
sir, malignancies of abdominal malignancies like ovarian
No,
malignancies,
not malignancy.
pancreas.
Not malignancies.
Yes. Even
Tanya, please tell them.
So, salivary gland infections,
Salivary gland infections, yes.
some drugs, sir. Few of the drugs also cause hyperglycemia. Few drugs, sir, like
No,
opiates.
but drugs, drugs can cause pancreatitis. It's not just hyperamylasemia. So the conditions which causes increased amylase, despite it is not being pancreatitis, will be head injury, burns, it is not ovarian malignancy, but it is ruptured ovarian cysts or torsion of the ovarian cysts, hollow viscous perforation. All of these conditions can cause increased amylase levels, but those
Pyelonephritis also.
pyelonephritis, but these levels will never be very high. So in case, what is the level that you expect it to be when you can say definitively pancreatitis? We know
More than 4 times normal.
what is your reference for that?
Reddit.
Huh?
Seen in some articles, sir.
Sanya? Amylase lipase levels, what level would you consider diagnostic for pancreatitis?
Usually 3 times the upper limit is what I
Three
read,
times,
sir.
yeah, 3 times is considered the thing. So the higher the value, it means it is more definite to be pancreatitis. That is all. So it is not a prognostic indicator, nor does it indicate any severity. So here looking at it, I think we do not have all the parameters, but whatever parameters are there do not, are not that elevated. For example, white cell count is not elevated. RBS is not, very high. INR is normal. So all of this indicate that this is a mild attack of pancreatitis, at least on this picture. Some, it may not always be that, but it, at least clinically the patient had mild epigastric, tenderness according to what you said. There was no guarding rigidity. There was no abdominal distension. So we can, as of now, consider this to be mild acute pancreatitis. Of course, this can progress to severe. So this is why we have to observe these people carefully. Okay, carry on. Next investigation. You put up. Okay.
Yes, sir. Ultrasound abdomen, gallbladder was over distended with severe wall edema with pericholecystic inflammatory changes. Multiple calculi were noted. CBD is dilated. Distal CBD calculus of size 6 mm was noted, and there is no intrahepatic dilatations. And pancreas visualized appears to be normal.
So what is this called, man? This picture. What is this picture called? Anybody? Was the gallbladder palpable clinically?
No, sir.
But still over distended gallbladder. So what do you think this is?
Mucociliar empyema, sir.
Yeah, due to what? Why is it distended?
Obstruction at the neck.
So this is called double impaction.
Yes, sir.
So there is impaction of the stone in the neck of the gallbladder, and hence the gallbladder is over distended. There is also a stone that has slipped through and it is in the distal CBD causing obstructive jaundice like picture. So this is one of the, if at all, when the gallbladder in this situation is palpable, then you say it is a what? Exception to
Years law.
Some law, no?
Years.
what law?
Years law.
What is
Courvoisier's law.
Courvoisier?
Courvoisier is a French surgeon. So it is a exception to this one, Courvoisier's law. Can anyone state Courvoisier's law? Because they will ask you in the exams. We know you are going for exams. Come on.
Yes. Sir, when there is a stones, if it is because of a stone in the CBD.
No. You can't say whatever you want. Courvoisier stated a law. If I ask you to say Newton's law, will you say something or what Newton has stated?
Statement.
Nikita?
Sir, if gallbladder is palpable in a jaundice patient, it is unlikely due to gallstones, sir.
Yeah, that is a gist of it. But in a patient with obstructive jaundice, if the gallbladder is palpable, then it is unlikely to be due to stones. That is the statement. It doesn't say it is impossible, it is unlikely. Okay. So, okay. So this looks like double impaction. Now,
Yes.
how will you proceed with this? Vinod, what are you going to do?
Sir, I'll go for ERCP, sir.
Straight away.
Sir, but as CBD is clearly dilated by according to ultrasound, there is no point of MRCP. No additional data.
See, did I ask you for explanation?
Okay.
What did I ask you?
Yes, sir. I'll go for ERCP.
Will you go for ERCP straight away? What is your answer?
Yes, sir.
See, Niranjan keeps telling you people, you still don't understand. See, when you are asked a question, understand the question and answer to the point. Did
Yes,
I
sir.
ask you for an explanation?
No, sir.
I said, is there need for MRCP? I didn't ask that question. I just
Okay.
said, you said you will go for ERCP. I said, will you go for ERCP straight away? Your answer should be yes, sir.
Yes.
Then if I want, I can ask you why. Why not MRCP? So then you can tell me why you don't think MRCP is necessary. Do
Yes,
you
sir.
think MRCP is necessary in this case?
No, sir.
Why not?
No additional information than this will get in MRCP.
Yeah, that is one thing. But what? What else? How old is this patient?
28 years, sir.
Are you expecting any other pathology?
No, sir.
If the same patient, same scenario is in a 60-year-old, 65-year-old patient, would you want to do an MRCP?
Yes, sir.
Why?
To rule out CBD malignancies.
Other pathology, don't say CBD malignancy. Yeah,
Yes,
it
sir.
is one of the things. It can be so many other things. So, in such, head of the pancreas malignancy or distal CBD stricture,
Yes, sir.
all of these things. So, you want more information in somebody like that. In
Yes.
a 28-year-old post-partum, two pregnancies, you are not likely to find anything else. And ultrasound has very clearly said there is CBD calculus. Usually, what is the problem? When do you need MRCP in these situations? Let us say your liver functions are mildly abnormal, but then the ultrasound, says something when you say, okay, I'll need to get an MRCP before I go for an ERCP.
CBD is not dilated.
No, but if CBD is not dilated, why do you need MRCP?
LFT deranged.
LFT is deranged, yes, but why do you need an MRCP? Or even an ERCP for that matter? Nikita, Praveen,
To make
Sanya.
As there is pancreatitis, we have to rule out the slippage of stones, sir. And
That is
if any
correct,
remnant
man.
of
But why,
stones,
why do you need MRCP?
so
Nikita,
to look
no
look for
answer.
any residual.
Sanya,
I'm not sure, sir.
see, in patients with pancreatitis, you can have distension, gaseous distension. Duodenum there can be ileus of the duodenum, and ultrasound waves do not penetrate through this. So you are not able to visualize the distal CBD. So even though there may be a stone in the distal CBD, it may not be visible because ultrasound has these limitations. So in those situations, LFT is deranged, patient has pancreatitis, you want to be sure. You can't justify doing an ERCP. Why can't you justify doing an ERCP in patients with pancreatitis, man? If you have not got any particular pathology? Vinod?
Sir, ERCP itself will
Correct. ERCP, it's a very it has got complications. It can cause pancreatitis itself. And apart from that, there are other complications. So to justify doing an invasive procedure in an already sick person, you should have, proof. So in patients who are deranged LFTs, but you are unable to visualize the distal CBD and not sure whether there is a stone there or not, sometimes the stone might have passed. In that case, you may want to wait and watch. You may not want to do an ERCP at that time. So that is the reason why you do MRCP in those situations. Okay, I agree with you. Niranjan, any comments?
No, sir. The same thing. So when there is obvious LFT derangement, and if they are able to visualize the lower end of CBD, and there is whenever there is no bowel gas obstructing that, and if they are able to clearly comment that CBD is dilated and IHBR is dilated, and they can localize a stone, I will not do an MRCP.
MRCP, correct. So here I agree with you. Vinod, you are right. So you want so. Okay, now what are the things when you do an ERCP? What will you do with ERCP? What are the prerequisites?
So patient should be stable, and he should the routine investigations like INR should be normal.
INR. See, patient should be stable is a very difficult thing. If the patient has severe pancreatitis and temperature and tachycardia, will you not do an ERCP?
Will do.
You will still need to, because that is a treatment of choice. So hydration of the patient, and then as you said, PT-INR, you need to ensure that their coagulation profile is normal. If it isn't, you have to correct it before you do an ERCP. That's all. Hydrate the patient, give them antibiotics to cover the procedure, and then may ensure that the coagulation profile is normal. Fine. Okay. So what are the things they do in ERCP? Have you watched any procedure?
Yes, sir.
Tell me, what do they do? For starters, tell me, what scope do they use?
Scope. Endoscope.
I'll hit you, man.
Sorry, sir, I don't.
Hey, Nikita?
For everything, it has to be endoscope only. Sir is asking what kind of endoscope.
Sir, I don't know the size, sir, but flexible endoscope.
Not the size.
I'm
What
not
is the
asking
difference
size.
between a regular endoscope and for endoscope for ERCP?
ERCP.
The one which has
Huh?
the one which has a port to send the guide wire, sir.
That
No,
even the
like
normal
that even
endoscope
in
has.
normal endoscope will have a channel. Side channel will always be there. What is the common sense? What is the difference between a regular endoscope and the ERCP? For ERCP, what do you have to do? Where will be the
Insert the
ampulla?
dye.
We need an angle, camera.
Side viewing
What
scope.
is it called? Side viewing scope.
Come on, man.
Regular endoscope will have the camera in the front, in the center. For this, it will be on the side.
So
Because
because it's a
ampulla will
side
not
viewing
be in the
scope, you
center.
can see the ampulla easily.
Yes, sir.
Okay. So what do they do after that?
They'll find the duodenal papilla at which this.
Correct.
Yes, sir. And they'll try to lateral sphincterotomy was done, and then they'll send the guide wire.
Not lateral sphincterotomy.
Not lateral sphincterotomy, man. That is in
for
fissure.
Fissure.
Sir, at bilaterally they will do.
No. You can't.
Bilateral, yeah. What is bilateral?
To the sphincter.
Ampulla, there is only one sphincter of body. What is bilateral?
On either sides of the.
No. If you shouldn't do that. If you think
On
like
either
that,
sides of what? How can you do on either sides? Sphincterotomy.
normally, where do they do the sphincterotomy?
Correct. 10 o'clock and 2
Watch all these things. Nikita, do you know?
No, sir.
Praveen? Abdul, please enlighten them, man.
So at the junction of the body, one side, lateral sphincterotomy.
No, it's not. Come on, you shouldn't say lateral sphincterotomy.
No, in the sense, the incision is on
Yeah,
one
yeah,
side
that-
and it is
No, it's not at one side. You shouldn't say lateral in this. Okay, I think the homework is, I can't keep on feeding you all the information. Homework is go and ask Dr. Vijay Kumar tomorrow or Dr. Purna Chandra, where do they do the sphincterotomy? Post the answer in the group. Okay. Yeah.
okay, sir.
So it is called a pre-cut. Okay, it's called a pre-cut. Why do they need to do the pre-cut?
Sir, because of obstruction, there's a spasm that can be relieved and we can guide the wire.
You need to
Have
enter
you
this.
have you people seen ERCP? No, not
Yes,
at
sir.
all.
I have seen, sir.
If
Yes,
you're
yes,
seen,
yes.
what is common sense? Use your common sense. Where do you have to cut? It is not definitely not lateral. Duct ampulla, there is one more duct also gets inserted. If you cut laterally, what will happen?
Pancreatic duct. We can injure the pancreatic duct.
So it has to be. Can it be anterior? Can it be posterior? I mean, like 6 o'clock, 10 o'clock. Sorry, 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. So where it's usually cut. If you do it below, what will happen? You will injure the duodenum. So it has to be cut along the CBD. So where will it be commonly? It will be between 11 and 1. You do the pre-cut between 11 and 1 o'clock. But you have to tell us why more clearly. Read and tell us.
Okay, so you do the pre-cut and then what do you do? Come on, man, quickly. Why can't we keep wasting time?
Sir, we'll pass the guide wire and through the guide wire we'll clear the
Pass the guide wire and then what?
we'll pass the
See, there is a catheter first.
Cannulate
So you
with
cannulate
the
it and
catheter.
inject the dye to ensure that you are in the CBD.
yes, sir.
And then you pass the guide wire and over that you pass the what? What do you want to do? You pass a Fogarty balloon catheter. What is the size of the Fogarty in this case? Biliary Fogarty. Have anyone of you seen embolectomy done for vascular cases? Sanya, have you seen an embolectomy?
I've seen, sir. I've seen, I
So
think,
what
two
French of
occasions.
Fogarty do they use? Vascular Fogarty.
Sir, I'm not sure about that. I've seen how Fogarty is used. I didn't concentrate on the size.
So what French of Fogarty do they use here in biliary situations? I think all of these things you should read up, man, properly. Usually
5 to 6 French each around. Usually 5 to 6 French.
so you then pass the balloon and then sweep the CBD and remove all the stones. After that, you have to repeat the cholangiogram to ensure that there is no. So you have to ensure again that no air bubble goes in, because if air bubble goes in, it gives you an impression that it may be a bile duct stone like thing. So you have to radiolucent stones will appear like air bubbles. So that is why you have to be careful that your dye there is no air bubble inside your syringe, and you inject and ensure that the entire CBD, the even the LHD and RHD are also visualized properly. There are no stones. Sometimes you can have stones quite proximally also. So you have to ensure that, and then you pass a stent over the guide wire to lie in the distal or the very proximal CHD, and then the end comes out through the papilla into the duodenum. So that is the entire process of ERCP. If there is a stricture, the sphincterotomy should be wide enough so that you are then able to do all this procedure and also pass a bigger stent so that the stricture remains patent. Okay, so that is the process. Niranjan, anything to add?
No, sir.
Okay, so after ERCP, Praveen, What are the things that you are worried about in these patients?
Uh,
You've done a
in a
pre-cut, you've done a big pre-cut, and
sir,
then post-operatively the patient suddenly becomes hypotensive and tachycardic. What are the things you are worried about?
sir, injury to pancreatic duct, sir.
No. Why injury to pancreatic duct? What will that cause?
Is it injury or
Okay, sir,
something
since
else?
Bleeding.
Is it injury? You do very rarely you injure the pancreatic duct. More than injury, what is it? Irritation of the pancreatic duct. How do you do
irritation,
that?
yes, sir.
How do you do that?
But
How does the irritation of pancreatic duct happens?
If the stent is placed in the pancreatic duct, sir,
No, not the
No,
stent.
no.
Nobody
Stent.
will place
How
the
How will you
stent
place a
unless you
stent?
want.
Guidewise.
guide.
See, unless you want to place a stent in pancreatic duct, nobody
You
will
will
place
place the
wrongly in the.
stent in pancreatic duct only when you irritate the pancreatic duct repeatedly and you are scared of pancreatitis. That is when you place the stent in pancreatic duct, not routinely. Common sense.
Repeated.
Use your common sense. When will it happen? Irritation. Sir was telling now. Repeated.
Repeated
You
guide
will
wire insertion.
Yeah, you will find it difficult to pass the guide wire into CBD, and repeatedly the guide wire keeps on going into pancreas. That is what will lead to irritation of the pancreatitis, and that is one of the indications for PD stenting in association with CBD stenting. Normally, highly unlikely, nobody will do the pancreatic duct stenting normally, and generally you should avoid doing that.
So when the patient has tachycardia, tachypnea, and hypotension post ERCP, what are the things you are suspecting? Immediately. We just now said something. What is that? Nikita? Why is this silence, man?
Bleeding.
You are not Nikita, Vinod. Okay. Nikita's silent.
Sir,
Ainas?
just tell,
Ainas, I'm not asking you any questions because this is the first ward round you are attending. So just listen and learn. Okay.
Yes,
From
sir.
next class, we'll start asking you questions also. Don't feel left out. Ainas, are you
Yes,
there?
sir. Yes, sir. I'm there, sir.
Okay. Vinod,
Sir. Bleeding, sir.
bleeding and what else?
Thank you.
You just now, Niranjan asked you repeatedly this question. What is this? You can have pancreatitis, no?
Severe.
Pancreatitis and bleeding. These are the two things. In the very initial, because we have just finished the ERCP, in the first few hours, if the patient becomes unwell, these are the things you suspect. How will you know that this is bleeding and not, ERCP induced pancreatitis?
We'll repeat in HP, sir.
Hemoglobin won't fall that quickly, man. The bleeding may happen, but it won't fall quickly. First, you do an amylase lipase. And if that is very high, then you think, yeah, it's probably likely to be pancreatitis. If it is not very, see, there will be an element of hyperamylasemia. If it is, let us say, 340 or 350, something like that, then you should suspect bleeding because the patient has become, hypotensive, tachycardic, and all that. So you have to suspect there is significant bleeding.
Yes.
So how will you confirm that this is bleeding? Nikita?
the definitive investigation would be CT angio, sir.
No, even before CT angio, you can do something, no, quickly.
Endoscopy again.
Repeat
HB
endoscopy.
endoscopy and also HB hemoglobin will drop if it is drastic bleeding, so much of bleeding.
Yes, sir.
So hemoglobin, as we said, hemoglobin hematocrit, and then repeat endoscopy will tell you whether it's significant bleeding or not. And then how will you control this? How will you control the bleeding? Sanya?
Balloon.
The embolization, if that is available.
No, that is later, but you have already done an endoscope. How will you control it?
So then cauterize,
Yes, cauterization. Then
oversewing it, sir. Taking a spoon.
Endoscopically, what you can do apart from cautery?
Balloon dilatation can we do, sir?
no. Why? If
No,
you will
not
cause even
dilatation.
more bleeding.
Yeah.
Small vessel which is just oozing. You do
Adrenaline.
balloon dilatation. You create it to be it will start hosing down.
You can do sclerotherapy by
Standing.
Endoscopic
Sclerotherapy.
clips,
What
sir.
are the sclerotherapy agents? Ethanolamine oleate, sodium tetradecyl sulfate, or cyanoacrylate glue.
glue.
So you
Okay.
can either, if at all you can see the point of bleed, you can either cauterize. You can use two methods. You can inject with adrenaline and also cautery. Never use one method because it will never be sufficient. You can either use a heat probe along with the injection, or you can use a cautery with injection, or you can use the clip. If hemoclips can be used, if you can see the point of bleeding, you can apply clips to the in the usually it will be from the sphincterotomy site, so you can apply clips. So these are the methods which you can use. If endoscopically, if the bleeding is very significant and you can't see much, when the visibility is very poor and there is a lot of blood in the duodenum, in that situation, what Sanya said is the next option is to go for a angiogram and selective embolization of the vessel wherever it is bleeding from. So those are the usual strategies for control of bleeding from the in the post ERCP status. Very rarely do you have to operate on them. Most of the time you will be able to manage with these. Okay.
Yes.
Let us say the patient is okay first 48 hours and then he starts becoming unwell, starts vomiting, and again there is some hemodynamic instability, abdomen starts distending, pain and back pain and all that. So what do you suspect now?
Perforation, sir.
Correct. Where?
Most probably at the site of
So
in the
duodenal
duodenum,
perforation, where does it usually happen?
posterior wall, sir.
Yeah, posterior. So that is why it takes time for it to develop and for it to manifest clinically. So that is why you should have a very high index of suspicion. What is the diagnostic procedure of choice to demonstrate the perforation?
Barium.
Come on, you shouldn't talk like that. Barium is given up long time ago. When there is perforation, you want the entire peritoneal cavity to be filled with barium and cause severe barium, peritonitic reaction.
No, sir. It's
Nikita,
just an X-ray
you are
just
actually worsening day by day. Your answers have become, you are answering much better when you first started. When have you done barium in the last? I can't remember doing a barium at all. Praveen, how will you diagnose a perforation?
Sir, by CT, sir.
Correct. So CT is the investigation of choice. Why not just a plain X-ray of the abdomen?
Cannot know the source of point of perforation, sir.
See, gas in these situations may not be that much. So
Yes,
it may not show up as free gas inside the abdomen. So
yes,
a
sir.
CECT is the investigation of choice. It will show a leak of the contrast, what is called extravasation of the contrast from the perforated site. It will also, as you said, demonstrate the site of perforation. It will also show other damage that might have happened.
Yes, sir.
So CECT is the investigation of choice. Okay. Let us say the patient has perforation. What will you do? How will you manage this patient? Vinod?
Um,
You thought this is a very simple class, no? Nothing much in there. There is nothing to worry about. Majority of you have not answered any single question of mine. So it just shows you that any topic, we can go on asking you questions without you getting answers from you. So don't underestimate ward rounds. Sania, please tell us. You tell us, how do you manage a patient who has got post-ERCP perforation?
So surgery would be the treatment of choice.
No,
No, Sania. What are you going to do? I didn't expect that answer from you. Surgery is not the treatment of choice. Abdul, come on, man. Abdul, are you there or Abdul not there? Answer, somebody answer. Is Abdul there or not?
He's there, sir.
Sir,
He's
yes,
there.
sir.
Why is he not answering then? Abdul, have you muted yourself?
No, sir, he's not muted also.
He's got an emergency.
No, sir, no, he's not muted. He's unmute only.
So Abdul is not answering. Okay. See, please remember, these are very difficult situations. In surgery, you can't go in that in a very, very difficult situation. You will not be able to do anything.
and most of them will be very tiny perforations.
Tiny
Like,
perforations.
you won't be able to localize it, and there will be a lot of edema. Sutures will not hold, and there will be most of the times will settle down.
Correct. So what you have to say is, you have to shift the patient to ICU, give them oxygen, treat their pain, give them fluids, keep them nil by mouth, put a Riles tube, and put it on continuous drainage, give them high dose PPIs, start them on octreotide, IV antibiotics, and supportive care. IV fluids ensure urine output. And as Niranjan said, majority of them are small perforations, very difficult to localize, very difficult to treat. Because of pancreatitis and also the problems associated with perforation in the very difficult area, it's very difficult to deal with these things. So you don't have to do anything. It will settle. You just have to support the patient and ensure that what are the complications that can happen in these situations? Sanya, you have done all the things, conservative treatment, but what can happen?
So peritonitis only if it doesn't
Usually not
supply.
peritonitis. Peritonitis is very rare. We keep telling you this perforation is not as if it is a big hole. It is a tiny perforation most of the times.
Localized abscess formation, sir, then.
It is a very difficult thing because you can have very, localized abscess formation, which will keep the patient sick. He will have spikes of temperature, and, in a high catabolic state. And because, so this abscess is in a very difficult position, you have to try and somehow radiologically drain this. Occasionally, you may have to do a diagnostic laparoscopy after getting the sufficient information that where exactly is the abscess, and then maybe put drains into this abscess cavity, wash out that area and come out. So that is the most difficult. This can actually, and also this can become a fistula post, your drainage, and that is a difficult problem. So it can be either a pancreatic fistula or a bowel fistula where you can be leaking bile and other intestinal contents or even pancreatic juice. So that you don't take them lightly, though the treatment of choice is conservative. It can be difficult. It can form abscesses, it can form fistulae. So those things you have to guard against, which is why initially when you have a high index of suspicion, attack it with all the armamentarium that you have strongly so that you minimize the damage. Give them proper high end antibiotics, start them on octreotide, suppress the, gastrin-induced pancreatic secretion, and also suppress the gastric secretion by giving high dose PPIs, suck out the gastrointestinal tract, and give them IV fluids and manage them. Niranjan, anything to add? Hello? Hello? Okay.
Yes.
Right. So Vinod, now this patient has had an ERCP. What does he actually have? So tell me now. Go to the next investigation.
MRCP was done, sir. It's showing a distended gallbladder with multiple small calculi. Largest is 7 into 6 mm. With the fundus of gallbladder showing a wall irregularity suspicious for perforation, and the CBD dilatation of 9 mm with the distal CBD calculus of 3 mm. And there is no intrahepatic.
So what was the plan in this patient?
ERCP with laparoscopic cholecystectomy was done, sir, in this patient.
Okay, so what was the thinking behind doing both procedures simultaneously?
There is perforation in the gallbladder, which is
yeah, but why don't you do an ERCP, wait and do the laparoscopic cholecystectomy next day? What is the purpose of doing both procedures at the same time?
peritonitis. Patient will.
No, but ERC, what will happen if you do an ERCP and then do the laparoscopic cholecystectomy next day? Patient has no peritonitis as such.
Yes,
You
sir.
clinically said there is no evidence
Yes,
of guarding rigidity. You should have asked this question. There is an answer to that, but you should know the answer. Sania, why do you think you did both procedures simultaneously?
So since patient already had pancreatitis,
What?
is it because of the pancreatitis he had already?
Correct.
Sir?
Okay.
Yes, would add on, if at all it adds on to the pancreatitis, then you.
I agree. See, I'm not disputing the fact that you needed ERCP, but why both procedures simultaneously?
So that's what, after doing ERCP, if the pancreatitis aggravated.
So what? You have done ERCP and you put a stent. So whether
And
you
you
remove
did
the gallbladder or not, the patient, if at all the patient is going to go for pancreatitis, she will. So how will your removing the gallbladder address this issue?
This perforation of gallbladder, so plus slippage of stone again can add on to the pancreatitis.
No, but there is already a stent there, so it won't cause any problem.
Yes, sir.
Abdul? Is Abdul not there because he's not answering anything? Abdul?
Somebody call up and find out, no?
See, the thing is, I think Niranjan will answer this question, but my interpretation is the patient is not unstable. Patient is stable. Is a young patient. Is a young female with this one, and there is, if the if facilities are available increasingly, you are able to do an ERCP and laparoscopic cholecystectomy in the same setting. I think that is the reasoning why they did it. Niranjan? Niranjan, are you there? Hello?
Hello, sir.
Niranjan just now spoke and then I don't know whether he's there or not. Niranjan?
Hello,
Sir is
sir.
there.
So did you hear what I said?
ಇಲ್ಲ ಕೇಳಿಸ್ಲಿಲ್ಲ ಕಾಲ್ ಬಂದಿತ್ತು.
Basically what I said is that patient is a young female who is clinically stable. And nowadays, ERCP and laparoscopic cholecystectomy are being done in the same setting, which is why it was done. Is that correct?
Yes, sir. Yes, sir. Patient actually, except that first day. Hello.
Yes.
Except for the first day when she had acute pain, in fact, the next day patient was absolutely pain-free. I didn't believe she had pancreatitis, although amylase lipase had risen a little bit. So probably it would have been a past stone. Probably that is what we felt clinically, or there might be some stone which is stuck and there is no pancreatitis, like probably just an edema. So, but next day when the patient LFT started to have a downward trend, in fact, the patient was planned for ERCP the next day, but medical gastroenterologist was somehow hesitant to do the. He felt that it probably will worsen pancreatitis. Although I tried to argue with him that there is no clinical pancreatitis, it's just probably a sequelae to
Hyperamylasemia. Yeah.
like hyperamylasemia. So he somehow wanted to wait for 48 hours and see. So the ERCP got postponed. Next day, ERCP, the LFT was showing a downward trend, but enzymes are still little bit on the higher side, not completely normal, not very high also. But bilirubin was never high. So there was a doubt. So then he left it to me saying that if you want ERCP, you can we probably can avoid ERCP. If you want MRCP, you do it. If you don't want, otherwise go ahead straight away with surgery. But I somehow felt since the lefties are not completely normal, and first day there was an impacted stone which was seen at the neck. In fact, they had repeated the ultrasound also, the medical gastro people, which had showed that the CBD was normal now. So I didn't want to land up in a post-op cystic duct blowout and leak. So I ordered for an MRCP. MRCP revealed that there is a stone in the terminal end of the CBD. So we went ahead with ERCP and lab chole because, as you said, patient is young patient, and clinically I didn't believe that it was pancreatitis. And even though if it was pancreatitis, it was just a sequelae to the impacted stone, and she was completely stable. And nowadays, there is increasing evidence that you need not have to do it like wait for 24 hours after
24
ERCP.
hours.
You can do it simultaneously.
Only in patients who are sick, patients who have
Very sick,
significant
you try
pancreatitis,
to avoid. When there is severe
patients who have got
pancreatitis,
who are in ICU.
you can wait.
Yeah.
You take away
Patients.
the cholangitis picture and then wait till the patient is stable and then take them away for lab chole. Only question is whether to do ERCP first or lab chole first.
Sanya.
Yes,
Hello.
yes, sir. Yes, sir. Yes, I'm
They
here,
did
sir.
the procedure, I think, the wrong way round. Gallbladder first
Yes,
and then
sir.
ERCP second. What is the problem with
Yes,
that?
sir.
Two problems.
Of doing lab chole first, followed
And
by.
then ERCP later.
So when they are stenting the CBD, can they dislodge the clip that we put in the cystic duct?
No. I think they must be really bad to do that, but not that. But what are the two problems? Vinod?
Yes, sir.
Abdul, are you able to talk now? Abdul is not able to talk. Okay. See, the thing is, one is, if you can't cannulate the CBD and you are not able to, stent it, and you are not able to, put the stent in and remove the stone, you have already done the lap chole, then you have no access to the bile duct. You will have to wait for the intrahepatic biliary dilatation to happen, then do the PTBD, and then do what is called as a rendezvous technique and pass the guide wire through the dilated intrahepatic biliary tree, and then it coming out through the ampulla, and then railroad the stent over that. And that is a complicated procedure. So that is one of the main reasons. So if, for example, if you have done the ERCP and you are not able to cannulate, you can tell the surgeon, look, boss, I have not been able to do it. Then you can cannulate through the cystic duct, and then the guide wire can be passed that, and then you can pick it up from the ERCP and then pass the stent over it. So that will be the advantage of doing a ERCP first compared to doing the ERCP second. The other thing is the advantage of having a stent put in will give you the sense of security. You know where the CBD is because there is a stent there. You can feel the stent. So in case there is any problem with the callus triangle and things, you can work your way around it because you know that the CBD is safe because there is a stent put in. So that is the added security for the surgeon when he is doing a lap chole in acute situations. See, the patient may say, I've got pain for 2 days, but the patient may have pain for 7 days, and that may be a difficult gallbladder because of that. So if you have the security of a stent in the CBD, that will make your surgery a bit more easier. So those are the two reasons why you want to do the ERCP first compared to lap chole. Niranjan, anything to add?
Nothing, sir. I agree, sir. If it was up to me, I would have asked them to do the ERCP first, and then I would have done the lap chole. It just for his convenience sake, and he was pretty much confident that it is a very small stone, and he won't find any difficulty in putting a stent. He wanted, he was apprehensive about bowel, gas into the bowel, causing swelling and making the surgery difficult. So even though carbon dioxide usage will prevent that. So I was arguing him for first ERCP and then surgery. He probably was held up. It was just to his convenience sake. He wanted us to do this thing, and he was pretty much confident of doing ERCP. Ideal scenario would be to do a ERCP first and then go for lap chole. Because as sir was saying, if it is difficult to cannulate and if you can't find the sometimes ampullary opening also sometimes will be difficult to in especially if there is any diverticulum at the ampulla or there is edema because of the stone at the ampulla, you will not be able to find the ampullary opening also. So
Correct.
in those scenarios, it will be ideal if you have then access to cystic duct and then cannulate it from cystic duct into the CBD via guide wire. Reverse. Put a
Absolutely.
guide wire through the cystic duct into the this thing. So ideally, it should be done the opposite way.
So for your information, patient who is clinically stable with no hemodynamic instability, when the patient, and abdomen is soft, if there is still CBD stones and gallbladder to be done, nowadays the trend is to do it together. You can do ERCP first and then do the laparoscopic cholecystectomy in the same intraoperative setting. Or if sometimes even there are surgeons who are confident who will do intraoperative, laparoscopic CBD exploration, but not necessary. It's a very unnecessarily laborious procedure when the ERCP can be done much more easily. So don't stand on vanity to say, as a surgeon, I can handle everything myself. You take help of people when it is a much simpler procedure. If as Niranjan said, if there is a duodenal diverticulum or a very tightly impacted stone at the terminal CBD, then you can attempt to do it laparoscopically, but otherwise do an ERCP first, then do the lap chole. If the patient has moderate or severe pancreatitis with needing inotropic support, ventilatory support, and renal support, such patients do the ERCP to deal with the acute pancreatitis and cholangitis, which is usually present. It will be incipient cholangitis. If it is not an overt cholangitis, then you have tackled the major problem. You drain the CBD, drain the infected bile and pus, and and remove the stones and put a stent in. So the CBD is now drained. Then you can tackle the gallbladder at a later date once the patient settles down. Once they come off the ventilator or inotropic support or renal support and all that. or sometimes, they will improve so quickly. In 48 hours, they will be ready, and then you can do the gallbladder. So generally, if the patient improves well, do the lab chole in the same clinical setting as that admission. If the patient is very bad, then wait for 6 weeks and then do the gallbladder. So that is the general accepted norm according to the Japanese classification of acute cholecystitis. Okay,
Adding to Sir's point, why you have to wait for 6 weeks is, in addition to that, there can be a possibility of a pseudocyst or pancreatic necrosis. So the further you delay in cases of pancreatic necrosis, you can do this procedure simultaneously or in
Correct.
pseudocyst.
Yeah.
So you don't want to go ahead like twice, like for lap chole and then again for pseudocyst in a few weeks.
Correct.
And two more scenarios where I would want the stent to be in addition to these scenarios, is one where there is a Mirizi syndrome. Second, when there is a large stone, which will be difficult to usually remove through ERCP until and unless you have advanced equipments like laser lithotripsy and spyglass.
Spyglass, yeah.
So in those two scenarios, I would want the stent to be there before I take them up for surgery.
Okay, I think it's 10 o'clock now. So we have had good discussion on gallbladder associated pathology, ERCP and everything. So it's not necessary to have 10 cases. You can have detailed discussion on one. And I think I'm sorry to say none of you are answered very confidently. So all of you go up and read about these things. Okay.
And all the more so, it's a very common problem, and you will be seeing so many gallbladders day in and day out. Like me and sir are very much surprised that you people are not able to answer these simple questions.
Yeah, absolutely.
And you
Okay.
people are managing them daily. Almost
Correct.
every like 2-3 days, you are having one gallbladder.
And many of them are complicated gallbladders. I think the last 3 months we have had a run of very severe bad gallbladders. Niranjan, me,
Yes, sir.
and sir also. Okay. I think, we cannot discuss the second case now, but all of you read up, including Sania. Okay. Good night.
Good night,
night.
sir.
Right.